This video is created for physiotherapy education and learning purposes only. The demonstrations and/or explanations are as per our experiences and are generalized and may not be appropriate for every patient or condition which is more specific. This content should not be used as a substitute for textbooks but just as an aid to formulate answers better.
Hi, this is Dr. Ravina here, and today we are going to talk about pain, the definition and methods of assessment. Now, there's also pain classification and pain management, which are in the upcoming videos, but this particular one is going to mainly focus on the definition and the various methods of assessment. Before proceeding, let's look at the most commonly asked questions in the previous year university papers. So if you see that there are multitude of questions which are asked as 3 markers, 7 markers, and mostly about definition and different methods of assessment. Now I've just wiped off here the explain pain gate theory because that's not a part of this particular video, and maybe in a subsequent video we will discuss that. But currently I would like to focus on the definition and various methods of objective and subjective assessments of pain in adults as well as children in this particular video. Let's first look at the definition of pain. Okay, so here I have cited 3 different definitions which I've got from 3 different sources. So the first definition is given in Sullivan, which talks about pain as a perception or identification of a stimuli as painful. Okay, the second one I have quoted is from Low and Reed, which was also by Walsh, which was presented in 1997, which states that pain is an unpleasant sensory and emotional experience linked to actual or potential tissue damage. And the third definition of pain is from the official body of International Association for the Study of Pain, which was quoted in 1979, which again quoted pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So we need to know that definitions have to be word to word, which is why I have provided the references so you can put the definition and probably quote the reference if possible in your answers. Let us now look at the various methods of pain measurement. So broadly, if you classify pain measurement, it is subjective interview and tests and tools. So from my experience as an academician, what I realized is that whenever a question comes about the assessment of pain, students always start writing about VAS, about NRS directly without even mentioning about the most basic tool for assessment, which is the subjective interview, which all of us do while taking the history. Okay, so now a subjective interview basically helps in developing a positive therapeutic relationship between the patient and the therapist. Okay, it is a combination of both closed-ended and open-ended questions. Open-ended in the sense that it's like we allow the patient to talk in the form of a paragraph, and closed-ended could be just a yes or no question or little or more question where we are just giving them limited options and they have to choose in those options. And of course, the interview is always taken in the language which is most comfortable and understood by the patient so that we get the right responses. So now if we look at the subjective interview, usually asked questions which the patient answers on the basis of his or her perspective is the chief complaint, okay, which is usually quoted in the patient's language. Okay, we need to ask about the mode and the time of onset of pain. We need to ask about the history of treatment, whether they have undergone any other forms of treatment before, whether it is medical, whether it is surgical or anything else. Okay, we need to talk about the pain progression, how it has progressed over a period of time, where it is located, what is the intensity of pain at the moment, since how many days it is present, which is duration, what kind of pain is it, okay, whether it is burning, whether it is dull aching, whether it is some other form of pain that they would like to describe, and whatever else they want to add in the description of their pain. We also need to discuss about the pain patterns. That means whether there's a diurnal variation, that means in the mornings the pain is more or evenings the pain is more, or seasonal variation wherein during monsoons the pain increases or during winters the pain increases. Okay, and then we need to discuss about the current aggravating and relieving factors and the functional limitations. That means which movement increases the pain, which movement relieves the pain, and what are the limitations the person is facing right now. So all this will give us an idea which movements are painful and which are pain free. So then we can design a rehab protocol likewise. And finally, we need to understand what are the medications the person has taken, and if along with pain, if there is any associated systemic condition or symptom that is present, like if there is a fever or there is a weight loss, we need to understand that, because it gives us an idea if there is any systemic infection that is associated, like tuberculosis or any other bacterial or viral infection that we need to look into. Now, just to summarize, an easy way of remembering what to write here is old cards. So onset, location, duration, character, aggravating factors, relieving factors, treatment, severity. So just a mnemonic for you to remember is old cards. So this is all about the subjective interview of pain assessment. Let us now look at the various tests and tools that are used for pain assessment. So for ease of writing, I have divided into adults and pediatric so that it is easier for us to look into each one separately. So in adults, we have the visual analog scale, the numerical pain rating scale, the verbal rating scale, the body diagrams, pain questionnaires, and health related quality of life questionnaires, which pain assessment is a part of. For the pediatric population, we commonly have the Wong-Baker's FACES pain rating scale, we have the Oucher scale, and we have the behavioral and observational scales. Let's look at the widely used pain assessment scale, which is the visual analog scale, or VAS as it is called by many. Okay, so you can see on the right, it is a 10 centimeter line with 0, which is on one end, which means no pain at all, and 10, which is on the other end, which means pain as bad as it could be. So even though it is subjective, but it is easy for patients to understand. Okay, so you just present them this line and then you tell them that mark on the line based on whatever their perception is of their intensity of pain. So suppose they mark this point, which I've placed the pointer on. So once they mark that point, what you do is you keep your regular 10 centimeter scale on top of that and see whichever is the closest whole number to it. Okay, from 0 to 10. It's a good prognostic tool as well. So if you have given say 4 sessions and then you want to measure what the patient's perception is of their pain, and they had marked this point which is currently on the VAS scale, okay, and say after 4 or 5 sessions they come here. Okay, so this tells us that it is more close to 0 now. That means their pain has reduced. So thus it is a good way to understand the prognosis or progression of pain. So if any other scale is used other than VAS for pain assessment, it has to be the numerical pain rating scale, which you can see the image on the right. Very similar to VAS, okay, but the difference is that if in VAS you only have 0 and 10 that is marked, which has the two extreme interpretations, okay, here you also have the whole numbers that are marked in between as well. Okay, so you have 1, 2, 3, 4, 5 till 10 that is marked, where again the patient is asked to keep a mark on the line that talks about the progression or perception of intensity of pain. So the more higher the score is, that indicates greater pain, similar to VAS, but the difference being, as discussed, that individual numbers are marked in between as well, unlike VAS, which only has 0 to 10. Okay, so coming to the next scale, which is verbal rating scale. Okay, a lot of people do not understand numbers. Okay, if you see especially the elderly or probably elder kids, if you can see, they might not understand what 4 or 5 means, or they get confused, or sometimes patients say हम नहीं बता सकते कि exactly कितना number का pain है. So for such people there is a intermediate scale that is found, which is the verbal rating scale. Okay, so what this scale does is that instead of numbers, it tells you descriptive words. Okay, so it can be no pain, mild pain, moderate pain, severe pain, very severe pain, worst possible pain. Okay, so if you can see, this is a 6 pointed scale that measures pain. Sometimes there are more or less based on what kind of adjectives or descriptive words we are using. But those who can't rate their pain on numbers, basically, they can rate their pain using these adjectives or descriptive words. The next common way of depicting pain or assessing pain is body diagrams. Okay, so as you can see the image on the right side, you have the anterior view and the posterior view. Okay, likewise, you can have the left side view and the right side view as well, where they can show the pain. So what you have to do is basically there will be some symbols, or you can generate your own symbols which depict certain attributes. So like for example, these X's are depicting pain, these slanting lines are depicting burning, these zeros or circles are depicting numbness, and these lines are depicting tingling. So you can mark on that. So if suppose a person is having cervical pain, okay, so this person can probably mark the neck or posteriorly that he has these cervical pains. Okay, that is common. So anterior aspect of neck or posterior cervical region, there is pain. Now if there is burning on this posterior aspect of the head, so he can draw these lines like that on top of that. Okay, if there is numbness because of this cervical thing, there is numbness in the thumb, then he can make these circles over here. Okay, so the circles can be made here, and because of that there is tingling that comes in this abductor region, so you can draw this tingling line. So basically you can depict whatever your symptom is on these body diagrams. Okay, so these body diagrams can also come as a part of other evaluation tools, like you have the McGill questionnaire. One part of it is also body diagrams. It is important that you give proper instruction so that it is easily understood by the patient. But the problem with this is you can't objectively define where the pain is. Okay, you just get an understanding of where the pain is, what kind of pain it is, what kind of symptom they are experiencing, but you can't, like how VAS or numerical rating scale was, you could actually place a number. That is not available in this particular aspect. So the next method of pain assessment is using some pain questionnaires, and most commonly used one is the McGill pain questionnaire. Okay, so as you can see, it's a self-reporting measure. Okay, so it talks about the quality as well as the intensity of pain. So like VAS and NRS talks about the intensity, but here we have an additional component of talking about the quality as well. So it has a body diagram, it has a pain intensity rating, which is from 1 to 5, and a list of words which the patient has to choose from describing their pain the best. So descriptors are sensory, affective, and evaluative, all three. Okay. So good and sensitive way to measure pain is what research has also stated is the McGill pain questionnaire. Now, in the previous slides, we dealt with certain ways of measuring the intensity of pain, and certain questionnaires we talk about the character of pain that the person is undergoing. But now we know that pain in itself, okay, is limiting the person's functioning smooth. Okay, so there is some or the other issue in the quality of life that occurs of the person because he or she is in pain. So for these reasons, they have developed some health related quality of life questionnaires, okay, which can be used as a prognostic tool and also for research purposes. Okay, so these questionnaires basically tell us till what degree pain has affected the patient to participate in their activities of daily living. Some examples which are provided in Sullivan are Dallas Pain Questionnaire, SF36, Pain Disability Index, etc. Now, as third years, we also study something called as outcome measures, which are taught to you after each joint assessment, correct? Or maybe after neurological assessment or cardiorespiratory assessments. Each particular condition may have an outcome measure to measure it. So just like osteoarthritis can have KOOS as a valid way of measuring, okay, the health related component, and you can have SPADI, okay, which is for shoulder related conditions, which can affect the health related quality of life. So now these questionnaires also have pain assessment as one of their components, which indirectly affect your quality of life measurements. So thus it is important that we mention about this aspect also in pain assessment. Jumping to the next scale, it is basically the Wong-Baker's Faces Pain Rating Scale. Now, definitely it is used for pediatric population with patients aged 3 years, but it can also be used for people older than that. Now, you can see this diagram here. You need to draw this as a reference for your Wong-Baker's Faces Pain Rating Scale in your exams to fetch you better marks. So basically, they just have to understand what each smiley means. Okay, so they've written that 0 means no hurt, so the person is smiling better. So the smile has reduced, but it's still there. That means it hurts a little bit. The smile has flattened completely. That means it hurts a little more. It has gone into the reverse fashion. That means it hurts even more. And it is the expressions are worsening. And the last, there's teary-eyed. That means it hurts worst. So you have to make the patient understand what each smiley indicates and how they should mark their pain. The next scale that is commonly used in the pediatric population is the Oucher scale. Okay, so the references are provided below here. So now as you can see in the right, okay, this scale basically provides images of various kids, okay, and their expressions. So then the children have to choose from those expression whatever is nearest to that. Okay, so it's a self-reporting of the intensity of the pain, similar to what we did before as well. But here, instead of a smiley or an emoji, we're actually using some child's facial expressions. Now, it's interesting that they have made this in different racial populations also. Like they've made it in Asians, they've made it in Africans, they've made it in Caucasians, etc. And so that, it's very relatable to the child and the expressions are understood as per their respective population. Coming to the last aspect, which is the behavioral and observational scales. Now, these are generally used in pediatric population again, and they might also be used for patients who are on ventilators, okay, or who are not able to give an answer or are unconscious or not oriented, okay, where you can't get a straightforward answer. These can be used in them as well, but majorly in pediatric population. Okay, so basically various aspects are observed. Okay, like for example, you have facial expression. So whenever you're doing something or some movement and you want to understand, the patient is not themselves telling you that there is pain or no, you can look at the facial expression, whether there's grimacing, whether there's frowning, whether there's a clenched jaw. That kind of gives us an observational interpretation. Then you look at the body movements, which is basically restlessness, rigid posture, guarding, etc. Then you look at the vocalization, whether there's crying, there is moaning, verbal complaints, some sounds that they are making, and physiological indicators, which can be like muscle stiffness. They are making their muscles very stiff so that you don't do the movements or something like that. Those are all behavioral and observational scales, and they are basically what you observe. So coming to the last and the most important part, what are you expected to write in the answers? So basically, obviously, the first point, which I always repeat on all slides, is read the question and the marks that are allotted. Definitions have to be precise from the textbook. Do not add your own words because you will lose marks if that happens. Okay. Please do not forget to write about the subjective assessment. Do not directly jump to the scales and the questionnaires, etc. Okay. Subjective assessment is an important part. It would be nice if you classify it into adults and pediatric assessment, so that will help you get better marks, and supplement your answers with diagrams wherever possible so that you get those additional marks. So just want to end by saying that if you have any other queries, please feel free to write your queries in the comment box. I'll try to answer them whenever possible. If there are any other videos that you want me to make, do let me know. And thanks for watching. All the best.